welcome Fiona Wilson in Bern here. She is an associate professor in Trinity College in Dublin and has over 30 years of clinical and research experience in sports and exercise medicine. So this is a lot. Her primary focus has been on athletes with back pain, with a lot of publications in this field. And she was the lead physiotherapist for over 10 years for rowing in Ireland. So we will hear an update on low back this afternoon from Fiona Wilson. So thank you.
Thanks very much. You can hear me. Thanks to the organisers for the invitation, Mario. Thanks for you hosting us so well. I have great memories of being here in Switzerland, particularly with the Irish team, Lucerne Regatta, training camp in St. Moritz. So lots of happy times. So it's really great to be here. So thanks very much. I love the title of this conference, Best Practice. So at heart, I'm a clinician. I have been a clinician for many years, and I always see myself as a clinician. I know a lot of you here will be clinicians, and maybe you're not involved in research and you're trying to understand research. And I think it's really important that your voice is heard and that we think about our research is clinically applicable. So I'm going to thread that through a little bit to my talk today. It's really hard to follow such brilliant researchers this morning. So standing on the shoulders of giants here. So I'm going to try and tell a few stories as we go through. So indulge me a little bit with that. So just as an introduction, was mentioned there, I'm a physio, I'm an associate professor, I'm head of the physio school in Trinity College. I'm a rower. It's like, you know how we define ourselves. So I'm a physio and I'm also a rower. And my research focus is on low back pain, but I also have done a lot on concussion and brain health in the last couple of years. And I was interested this morning with Kevin Wilkes' talk about the neurocognitive, because I think it applies to everything, and it's great to see that that's coming in. And obviously, we've focused a lot in our concussion work on that. I'm also a member of the World Rowing Sports Medicine Commission, which is great. So we get to really kind of influence policy from that point. So low back pain in context. I think it's really important to think about everything in context in terms of how does it affect the general population? And is this really an athlete problem that we're thinking about? And I think it seems a bit easier with things like hamstring and ACL because they're very distinct injuries. Low back pain can occur can apply to anybody. So most people will get low back pain in their life. I love putting this slide up for my students. I haven't had to do it so much since COVID because everybody understands epidemiology now. So this slide is talking about the cholera epidemic in the 1800s in London, which was the birth of epidemiology. So this is what I try to explain. But the doctor was called John Snow, who discovered it, and they all she's talking about Game of Thrones, and they all perk up a little bit and start listening. So that's who was the godfather of epidemiology, just for every day is a learning day. So nearly 10% of us at any one time will have low back pain. And it's a little bit higher in Western Europe, probably because of reporting. So that's a really big problem. It's the greatest contributor to global disability. So if you think of it in that context, then it clearly is a problem. Risk factors are interesting in the context of athletes. So sex of females report it more. Occupation, including lifting. So that's kind of where we're thinking, isn't it, in terms of sport. Obesity doesn't really apply to athletes generally. Smoking doesn't. Socioeconomic, does it or doesn't it? Well, we're going to discuss that. And then physical activity and lifestyle, obviously, that does apply to athletes. So let's get going on some stories. This is me as a student back in the day. Notice the beer stain on the there. That student card had a good time. So that's when I started rowing. Same hairstyle, for those of you who know George Michael. So they were good days. I just started rowing, and at that time I was training maybe 3 times a week, in between having a really good time and sometimes going into college. I picked up a little bit eventually. So that was the beginning of me getting involved in really quite a serious sport, which got more serious. But at that time, it was all about wake me up before you go. And then where have I ended up in terms of that journey and that research journey? So we'll talk a little bit about this at the end, but this is our latest infographic on managing low back pain in rowers, which is a culmination of quite a long period of time. So how do we start understanding low back pain in athletes? I love this framework. It applies to everything, and I get my PhD students to always think about this when they're talking about designing protocols. So this is the evidence-based practice model by Sackett. These are all the components we need to understand if we're going to understand anything in health and obviously in sports medicine. So it's not just the best research evidence, which is on the little corner there. It's all the other stuff, and see how important clinical expertise is in that model. So that's an important component of it. So those of you who are clinicians, and I want to say just working as a clinician with an interest in the other areas, that is important as well. But then there's also more to it. There's other components to consider. This is across all sports medicine as well. So there's a biological, and I think we're really getting to a place where we're understanding that quite well. Psychological, interesting in athletes, isn't it? And then sociological, and is that important in athletes? Well, that really is important for context. So we'll discuss that as we go through. So I was interested in doing some research, but I didn't feel it was for me. I didn't feel like I was somebody who could get involved in that, because my initial thought was research in low back pain was all about biomechanics. Physics was my nemesis when I was at school. I thought, that's not going to be for me. It sounds a bit engineering. So I thought, well, I'll just stick with the clinical thing, and they're the badges I got when I was qualified. So I'll go on a clinical career and try and understand sports medicine that way, and that will be my contribution to the area of interest. So across the world, across lots of different settings, I've worked, and each of these settings has given me something which has led to this end point of the journey, where I think I understand low back pain a bit better in athletes, but I think there's plenty more to learn. So I started off in London on junior rotations, doing a little bit of everything, getting people to cough sputum into cups, treating people after they've had a stroke, all kinds of different things, then on to senior rotations. Then I went to South Africa, where I worked in a public hospital, and then a sports medicine clinic, which was kind of a turning point because I got such amazing mentoring. And then I went on and progressed my career. And every single component of that has been important, because that's all added to my understanding of this small thing of low back pain in athletes. So if any of you are on that kind of journey, stick with it. It'll give you rich experience, which we will definitely use. So the first step, clinical expertise. So that's what I wanted to do. I got stuck into that. And that's where I was going to build my knowledge. I didn't know it at the time, so this is all retrospect. And sports medicine training, so how did I get better at that? Well, a bit of a lived experience. So I got more serious about my rowing. I joined Thames Rowing Club in London. That's a beautiful Thames Rowing Club, and became quite a serious athlete. And then I got some great mentoring in track and field athletics when I was a junior physio, working with senior physios. So we learned a lot about rehab and reacting on the spot to injuries. And this was a little bit of a curveball that I had. One of the rotations that I worked in, these are not my words, the Human Repair Factory. So this hospital was called the Royal Hospital, the National Hospital for Neurodisability, when I worked there in my first senior job, but it had just changed its name from the Home for the Incurables. So it was a brain injury unit. I was very much like, I'm not ever going to work in brain injury. It's not for me. I'm not good at neuro. I like to see someone come in and they look a bit better when they leave, not that I've done nothing, which is how I felt at the time. But the experience of working in a place like this gave me a great understanding for the importance of sociological, psychological, the resilience of the human condition, understanding pain. And I think any experience you get like that is going to be applicable for working with athletes. And then in South Africa, so I didn't work in sports medicine from the outset. I worked in Victoria Hospital there in Cape Town on the left. Got to know a lot of the gangsters in South Africa who'd been shot and stabbed and were like cats with 9 lives, who had amazing resilience. Again, understanding the human condition, physiology, what people can go through, expectation, like how we sometimes lower our expectation for athletes, different contexts that people were living in. And then I got to go to Johannesburg and work in an amazing sports practice, some athletes who eventually got a movie made out of them, which was kind of surreal, ones who became football heroes. I got great mentoring from Evan Speechley, who owned the clinic at the time. And then the craft of sports medicine, so trying to frame it a little bit, what has underpinned where I've got here with the understanding. So hours of input, mentoring, respect published research, but question it. And I think this is an important one. Anything that's published in journals, amazing research, it's the average response which is published. Just remember that. Where are our world champions? They're often outside that bell-shaped curve, aren't they? Or outstanding athletes, or are athletes who are on the up. So for those of you who are clinicians, you think, maybe this doesn't quite ring straight with me. That's not working for me. What that paper is saying or what that research is saying, my experience is different. We need to hear that. That's part of that Sackett model, isn't it? And I think particularly applies in back pain because there isn't enough good stuff out there in back pain. The work done in the general population is generally done in chronic low back pain. If it's done in acute low back pain, it's done with people who are in such poor condition they end up going to hospital to accident and emergency departments. So think about what that research is saying in it. And there are other stories outside of that. It's really important. So listen to what patients are saying and mentoring of good clinicians. So then patient values and preferences. This is an equal part of that model. So let's get back to the stories. Turning point, a letter to my younger self. So this is when I got my own experience of low back pain, and it was a very severe experience of low back pain. So I was doing well with my rowing in South Africa. I got selected to row for the South African team. I was supposed to be coming here to Lucerne Regatta, and that never happened. So if you have a look, I'm doing something funny with my leg there, it's turning out, and that's because I had gold medal around my neck, terrible pain in my leg that day and in my back, and I got a foot drop. So I got an acute episode of low back pain, severe. I remember the next race I did after that, I had a sudden locking of my back. I had to get one of the guys I rowed with, who was an army medic, to give me an injection, put me in the back of his car, drive me home from Durban to Johannesburg. What did I say? Do not tell anyone about this. And that became part of the story. We know that, those athletes. Don't tell anyone. This is weakness to me. I don't want anyone to know that I'm a broken athlete, a weak link. So this actually, horrible as it was and upsetting as it was, it set me on a path to understand this problem better because I couldn't get the help I needed at the time. And actually, I never even went to the ceremony to get my international colours. I got on a plane and went home and left South Africa at that point. It gets better. That's the sad bit. So then, let's when life gives you lemons, what do? You make lemonade. So let's turn this, and this is where I ended up. Amazing Trinity College Dublin, where I work. That's our amazing library. Some of you might have seen it on Star Wars. Yes, it was on Star Wars. And that's our front square. So what was I going to do next? I was going to explore the evidence then. So I did an MSc, and it was biomechanics. Yes, I made that step. So I got to better understand how rowers move their backs and hips with my MSc. And then let's put this into practice. So I thought, well, I've done my research bit. Let's start using this now. So then I was lead physio with Rowing Island, and this is when I got to travel here and all kinds of amazing places. And it was helpful, the research that I'd done and understanding low back pain. But really, I got a bit of everything working with that team. So best research evidence, patient values and preferences, those conversations you have with athletes in the treatment room. They're amazing, aren't they? And you remember them. And it tells you a lot about self-efficacy. I remember one athlete, the night before the World Champs, before he went out and won it, he said, do you know what? There's going to be an amazing race behind me tomorrow. I thought, there's an athlete with incredible self-efficacy, and it's understanding how that athlete will frame an injury compared to another. So then back to low back pain. So I kept the research going. I did a PhD, and there's multiple papers then that we got out of that. A lot of them exploring biomechanics, and I'll talk to you a little bit about that in a minute. Also, with the first group to look at the epidemiology of low back pain in a relatively small study. Nobody likes funding low back pain in athletes for some reason. I'm sure some of you have come across that. I think it's almost seen as a problem that's not sport specific. So these quite small studies, and luckily we're very collaborative as rowing medicine people. And then we tried to take it out. So as a group, we got together and tried to make sure information got out to the wider population. So education for athletes. So we've written a few pieces for World Rowing, and they ended up being the biggest hits they'd ever had on their websites. They're about a bit of education about how to manage low back pain. Can it be prevented? Probably not. I'll talk about that in a minute. That raised a flag, really, that we needed to do a little bit more to try and help so many rowers. And in the end, this is an injury that's wiping out people's careers. And not just that, it's actually going into their retirements as well and affecting their quality of life for the rest of their life. So we knew that, but we felt there was a lot more that needed to be done. So a gang of us got together and decided we had this big idea. We'd pull all the concepts. We'd take that Sackett model and try and create a framework for managing low back pain. And we hoped then it would be translatable to other sports. It was obviously going to be rowing specific because that's where we had our research. But we feel like there's lots of components can be translated. So we met in London. There's a gang of us there who physios for national teams across different teams. We've also got a biostatistician. And we decided we need to do systematic reviews in certain areas, a little bit like the Bern consensus statement. And we also need to hear from the athletes, but we also needed to hear from the clinicians and what they were doing in everyday life. And so we set out to do that. So then, revisiting the framework, could we pull it all together in something meaningful, thinking of those components? And we did a little bit of a new framework here. And I think this would apply to low back pain in any sport. So we have our epidemiology. And what are we going to get from that that's going to be useful for practice? We're going to know about risk factors. Are they modifiable? Can they make a difference? How common is it? How much of an alarm bell do we need to ring? Can we prevent it? I think we're saying no. Where's Phil is gone, is he? Can we prevent it? Can we make them more robust? Biomechanics is useful. We use biomechanics for etiology. How did it happen? But we use it a lot in rehab, don't we? So understanding the biomechanics is really important because they help us design our exercises. The clinician experience, what are clinicians telling us that works for them? These are people with a rich experience. It's that thing, do you want a plumber to come and fix your awful pipes that's got 30 years experience and seen every type of pipe possible, or the plumber that's just passed their exams and came top out of training? Kind of think who we know, don't we? So the lived experience of clinicians is really important, and clinical preference, what they know works, what they've seen working. And then the athlete's experience, and surprisingly, this is often not included in things like consensus statements. It's getting better. I was at a meeting recently about concussion, and there was lots of amazing stuff about where we're going, and as you all know, there's quite a long way to go to understand how we manage concussion. And an athlete put their hand up in the audience and said, this is all very well. You're saying more needs to be done before we know. What happens to me? Like, are you fiddling while Rome's burning? So what do I do in the meantime? So that was important, especially if we're going to start telling them what to do. Is it meaningful to them? So contextual factors, fears and beliefs, what do they know about it? And can we safeguard? And we talk more and more about safeguarding. So what else do we need to consider? Does prevention lie in the understanding of load management? We've come a long way with load management. And are there practical strategies that we can use throughout the season? Of course, this is where we are with low back pain, that you do too little, exercise you're here. and you do too much here. So there's a U-shaped curve that we know happens with low back pain. So we're on this side, aren't we, really, with athletes generally. Context. So one of our first papers was looking at the prevalence of low back pain and see if we can understand some of the risk factors. So for those of you who know about forest plots, this is a complete mess, this one. This means the research is all over the place, and this is because they're all using different definitions, different types of populations. However, we put it there just to really as a visual to show that it's we're so far from knowing exactly what the prevalence is of low back pain. Whatever it says is pretty high. So 86 studies, point prevalence. So at any one time, 42% of athletes had back pain. We're not really bothered about lifetime prevalence, not very meaningful in this group. But this says about half of the athletes in these studies had back pain in the last 12 months, which is really high. Now, there will have been athletes who are involved in sports probably that are associated with low back pain. And risk factors. This is interesting. History of low back pain, same with any other sports injury, isn't it? If you've had it before, you're more likely to get it again. Higher training volumes, you're exposed to the load. Periods of increased training. So today I've had 2 texts. Hi Fiona, can you see my back? I haven't been in clinic for a few months. But this is because November, that they had a break in August, September, and now they're training harder and harder, and now they're starting to break down a little bit, and they've got national team trials, and we'll see it again in March. Competing in sport for longer, well, it's, that's any kind of risk factors. Increased age, we don't know about that. Inconsistent. A lot of studies showed that women reported low back pain more than men, but that was inconsistent. So we definitely need to know more about that. And then mixed findings of protective effect of trunk muscle function. So studies that looked at doing more core stability, was that protective? They were very mixed, and partly because they just weren't done very well. So this is very recently published. We've done something similar in junior athletes, which are different. So the pool's incidence, about a third of them had low back pain, which is pretty high for kids, for a small age group of kids, aged 14 to 19. That's troubling, isn't it? They're doing sport for health, and it's giving them no back pain. So that top one, the risk factor, sports participation, that's wrong, isn't it? So it shouldn't be that they're taking part in sport. Something that's supposed to put them on the path to a healthy lifestyle is giving them an injury. That's where we could compare it to a group that weren't doing organised sport, that were maybe just doing a little bit of physical activity. Those who report other pains were also more likely to report low back pain, so concurrent lower extremity pain, being overweight, being a bit older. Girls definitely reported more than boys, and then a family history. So one of the things, or one of the best studies that I've done, because it reflected a lot of what I'd heard in the treatment room, listening to athletes' stories, so what they were telling us about their experiences of low back pain. This is important because it helps us change coaching practices and policies and procedures about how we manage athletes with low back pain. So there's a quote from an athlete: "You're the best liar in the world. I never told my coach I was injured." And that athlete told us they had such severe episodes of back pain, they'd go off and row into the side of the river and find some reeds and go and lie on the bank for a minute, hiding from the coach, and then get back in the boat because one of their legs went numb. So what did they tell us? Their experience of low back pain is influenced by a culture of secrecy. They don't tell people. They don't want to be seen as weak. They fear disclosing their low back pain will mean they don't get selected, and there was me lying in the back of a car going from Durban to Johannesburg doing the same thing. It can lead to isolation and can have an effect on their life beyond sport, because a certain number will leave the sport and then they go into somebody who's working who has regular back pain. Clinicians give mixed messages, and one of the athletes said to us, clinicians are always trying to outdo each other, say, "Oh, I'm the one who's going to fix you. I can't believe that you listened to that last person." And I know that we all know that happens, doesn't it? With confidence, I'm going to fix you this time. Hopefully we don't say that, but that's what they experienced. Or they would argue, clinicians would argue. And you can see how that happens with low back pain. We don't have these clear strategies that you have maybe with something like ACL or from the great work on hip and groin. It's still very misunderstood, I think. So one of the things that came out of this was rowers and support teams should be educated on multifactorial nature of low back pain and a culture of openness. Athletes are now treated as a commodity. And this same one that gave us that quote said, being an athlete is like being in a box of 12 eggs where the coach throws them all at the wall and keeps the ones that don't break. We've kind of seen that happen. They're not a commodity, they're humans. And a coach gave me kickback on this. I said, oh, I don't want to have athletes that are always complaining about pain. I want resilient athletes. So I thought, well, that's what education, I kind of get what he means. I meant what he meant. But this is about your best athlete might be the one with back pain. And you want to protect your talent. You want to protect everybody. That is safeguarding, isn't it? Providing an environment where they can be open and access care for their pain and injury. That is much safeguarding as all the other components we think about safeguarding. So clinical impact of this is thinking about the cultural influence and low back pain experience, the coach and the team. Have you created an environment which is optimal to the athlete? Being able to tell people they've got back pain. What do you think about, what kind of system do you set up when they're injured? Do you push them out and make them feel like they're not in it? I think Andrew was talking this morning about getting them to put football. So one of the athletes told us, if I can just be in the gym, they're all doing weights, but if I can be on a bike, at least I'm in the gang with them. Safeguarding, this is safeguarding. This is important. You have a moral and ethical obligation to protect athletes, to give them an environment where they feel safe telling you they have pain without repercussions. And low back pain is a clear one that taps into that. So encourage a rapid response. You've then got to put a system in place where if they tell you, you react quickly. And you're more likely to have a good outcome because of that. That we agree with each other. We have a clinical alliance. We're not saying completely different things to each other and outdo each other. And that we have a good communication set up. So then we did a bit of secondary analysis on that rich data set to try and understand what athletes understand. And they told us that the priority then is just meeting training volume. And Phil explained that really well this morning, that if they've done it, it doesn't matter how they felt or how bad it was, just ticking that box. So they're constantly told the volume that you do is your outcome. So if you go to Lucerne Regatta and you haven't done this many hours, you're not going to make the final. So it's about quality, and that's really education. And then they were obsessed with certain things like core. That word kept coming in, the core. And if they didn't, it was their fault. I've only got myself to blame. I didn't do enough of this. They were very focused on structural factors, and they wanted to know. They wanted to be told, it's a disc, it's a facet joint, it's a ligament. Why was that? Because they needed to know it wasn't in the head. They needed the thing that was driving it. And that's quite easy in ACL, isn't it? And if they didn't have the thing driving it, the worst thing that could happen to some of these was a normal MRI scan. And that's that, this is me. It's in my head, I'm bringing it on myself. So obviously, clearly, there's education. There's also this inevitability that if you row, you're going to get back pain. And that's kind of tragic that we have that, isn't it? And focus on physical strategies. So very poor understanding of psychological and social components. So this is where they're saying things like the disky fluid or whatever, bit of a tear there. And that athlete was actually pleased. They told us a story. And all of this went on. And eventually, they found there was a disc. And that's what it was. And I thought, well, at this point, that disc is probably well healed. And then this one, who was just very worried, there's something wrong, we don't know what it is, I had a normal MRI, and so that's worse now because there is definitely something. And that was really an athlete who'd been given poor education. So this is one that we've just done, so not for tweeting, where we've done it in adolescent athletes. very similar, but a culture of normalising pain. So these are kids going into a sport who are expecting to get low back pain, and they're looking at ones around them. And we should be providing a safe environment for kids. They shouldn't be thinking that's normal, should they? And when they think it's normal, they're less likely to report it and to see it as a problem. And it also changes them how they perceived and perceive themselves. So one of them said her coach was really mean to her. Said, "You're weak, and I think you're making some of this up. And, you know, if you want to be a proper athlete, if you want to take, you know, go on and be a serious athlete, you've got to suck it up and be a bit tougher." Kind of get a little bit what the coach is trying to say, but the lack of education for that coach was a problem. So then for clinicians, we did a large Delphi study led by the brilliant Kelly Wilkie, where this is where the clinicians get involved. So they told us what they do, how they treat low back pain. What they were telling us, a lot of what came out in our epidemiology study, so previous history, was important. Ability to maintain a consistent load across a season, shown excellently by Phil's graphics this morning, is these little spikes in load. So keeping it up. So that tells us about our rehab with low back pain. Keep that load up. What they're dropping in one place, we need to keep it up. Doing too long on the ergometer is a problem. That's been quite consistent. Psychological stresses. That came out very strongly in the clinical questionnaires and our Delphi study, and then we summarised it a little bit later. So bringing it all together as an example, we've got look at our research, athlete voice, and then important to add in coaches and a support team. But there's a bit of an alchemy in this, isn't there? It's not as simple as it looks. So what are we actually doing with low back pain? We're dealing with pain, and this is a big one, because with low back pain, we don't wait till the pain goes away. We know it's really complex. I think that's probably going into things like hamstring and other areas. But if you wait for an athlete to be completely pain-free in low back pain, you will generally struggle to get them back. So it's dealing with pain, and how do we do this? And I'll definitely put my hand up. There's a lot more needs to be done in athletes, low back pain in this area, understanding how they see pain, how it's framed. But then also restoring function, getting them back to where they were. So alchemy framework, biopsychosocial approach, we talked about that. Individually tailored, stratified care. We're not dealing with one injury here. We're dealing lots of things. And within that, it can be things like inflammatory back pain. So over the 30-odd years I've been practicing, I've seen 3 international rowers who have got axial spondyloarthritis. So they've got inflammatory arthritis. And that's what I was seeing, the start of it. So stratified care according to what's going on with them. Precision rehabilitation. I work a lot with immunologists in Trinity, and they talk about precision medicine and things like cancer care, precision medicine. So precision rehabilitation. And what do we know about association with pain, function, and return to sport? Not enough, but it's this thing chasing the resolution of pain. We know that in the general population that we can get people back to work with low back pain, even if pain remains. And evidence shows that return to work occurs before symptom recovery. So we need to start thinking about applying this in sport as well. I know it's different because we've got high performance, but it definitely needs to be a principle that's in there. So then multiple papers were published out of this, and eventually we came to our consensus statement where we pulled it all together. In terms of management, this was less than satisfying. So we looked at all the studies that are done in low back pain management. There were 36 studies, and only 13 of those were randomized controlled trials. There are no randomized controlled trials in surgery or injections, but we kind of had a look at them anyway. Everybody did brilliantly with injections. Everyone did brilliantly with surgery. I think those studies were just really the cherry-picked people, weren't they? So generally not done well, very few trials. Exercise was the most common and was associated with reduced pain and improved function. That's not a massive surprise, is it? But we don't know if it's a faster or higher return to sport. Exercise, I think we all know this, I'm preaching to the converted. Remain active. Exercise in acute low back pain is limited, and for persistent low back pain, it should be first line. So that's the general population. And in the study here, all exercise approaches decrease pain and increase function. There was no approach that was better than others. Brace yourself. Core stability was no more effective than other forms of exercise in the long term. I'll be leaving by that door. People don't like that. That's the evidence. That's what that shows. So why is core stability no better? Bit of my clinician experience in here as well. So there's an overemphasis on the isometric phase of training, isn't there? Staying at that, motor control, let's get this right and never let you move on from that phase. And that becomes this is the treatment for low back pain. Whereas actually it's phase one, you wouldn't do that with any other area. We saw some great stuff on shoulder, and you see how it quickly becomes dynamic. But I've certainly seen a lot of junior rowers who were given 6 months of planks, and that was expected to fix their low back pain. 6 months of isometric stuff, anyway, front planks, side planks, and nothing where they start getting dynamic and loading. So it lacks specificity for sport. For some sports, that position might be good, it might be useful. So certainly in rowing, you need dynamic movement through the trunk. I mean, even that exercise in The Guardian, it says it will get rid of your low back pain, basically, which is quite the claim. So there's no such thing as a bad exercise. If that plank is appropriate, then that's okay. But think about, where do you need to go? What are the demands of the sport? It came from the transverse abdominis fad in the 1990s. I'm old enough to remember it. I'm old enough to have been on courses and gone, I'm working with world champion rowers who don't have back pain and they can't do that, contracting transverse. I was like, the non-believer is in the room. And it's kind of filtered down a little bit and got misinterpreted, I'd say. So there's obviously some great stuff still in that. But it doesn't work particularly in rowing. And things like glute activation. So this is kind of throwing it back to the athlete. It's your own fault because you can't activate your glutes. And yet they've walked into the clinic. You go, well, how did they get off the chair if they couldn't do that? And they kind of look at me, well, what is she talking about? So again, that's all about sticking with that one phase. So specifics of the sport, in rowing, they're loading a bent back. And that is perfectly fine. That is an athlete who doesn't have back pain. So it's a curved back. The back spine can take load very well in that position. It's actually designed to do so. And then one of our little delves into the biomechanics is why, when rowers get on the ergometer, are they getting back pain? So on the left, this is them on an ergometer. So this is doing an incremental test. So 3 minutes, going up harder and harder. That bit in the middle is the brake, increasing and increasing. And you can see they're getting more and more flexed as time goes on. Then in the boat, they're not doing the same. Okay? So they're going through the same movement pattern. And then also from our EMG, we see that here, a rower without low back pain, as the same kind of test goes on, they're recruiting more and more of the erector spinae muscle. This means it's spreading out. And in this row with low back pain, a bunch of rowers with low back pain, their recruitment becomes more and more focused on one area. They become less efficient. They're not using the expanse of their erector spinae. So we know rowers do a lot of sagittal flexion. Cyclical loading increases risk of tissue creep, and you get inflammatory cytokines. You get inflammation in the tissues of the back, dampens down the mechanoreceptors, so that influences their proprioception, knowing where they are. We know cumulative mechanical loading is a determinant of low back pain. Thinking movement patterns is important. So this is one of the tests I do. Looking at the squat here. So the eyes go ahead. So kind of rower, hold themselves in this position. Keep their back fairly straight, shins relatively vertical, and a nice deep movement through the hip. Keeping the feet flat on the floor, or do they fall backwards? So the ones that don't have good hip range will fall backwards. Ones who don't have good trunk endurance, particularly in their extensors, will fall backwards. And then this is a test I always do when rowers come in, and actually I do it with anybody with low back pain. I look at their squats and their squat progressions, and I can use this as exercises. So can they squat to a high seat with hands crossed over their chest? If they fall back into the seat, then they've got probably poor range of motion in their hip, and they've got poor trunk control. And I bring it all the way down, using it as rehab, right down to here. What we need, all rowers need to do is a deep squat to a low step with repetitions, keeping the trunk in a relatively stable position. So the spinal extensor muscles dominates in rowing, very low activity from trunk flexors, but they're important when they turn around the rowing pattern. And then thinking about cumulative loading. So how can we change that? We think about their loading patterns through the season. And we know that actually it's the cumulative, which is the problem. We've seen that in workplaces, not particularly the spikes. That could be the inciting event. So rehabilitation, thinking about control of the motion segment, that's the beginning, the motor control. Range of motion to improve positioning. So hips and back pain is so important. And I was talking to Andrea, a lot of our rowers would have a hip problem, so we sort that out first, because they'll never actually get into the position they need to in the boat. Trunk endurance, so get out of the isometric phase and get them doing dynamic stuff in any sport. Early return to sport. Think about the effects of fatigue on their proprioception. We showed you the rower getting more and more flexed. Feedback where you can. And then specificity. Don't have them doing planks unless it's needed for that sport. How am I doing for time? How many minutes?
Yeah.
I'm okay.
Yes, but, yeah.
Yep. So thinking about rehab progression. So this is in our paper that we published, a consensus statement. So what we do when we see a rower with back pain early, manage the psychological, explain it to them, manage their pain really well. What we want them to do is move as well as possible and as normally as possible. And if that means getting their pain treated, then do that. So a lot of what I used to see, particularly when I was traveling with a team, is that hypervigilance. You'll all have seen that. When they go like that, you ask them to flex and they go, ooh. So the first thing I have to do is move. Why are you bending forwards like that? I don't know. So get them to move normally. They'll be scared of it. Any patient with acute low back pain will be scared of it. You will not get worse. You will actually get better. So getting them to move normally. Deload, but don't onload. So still have them doing something, and as much as possible to keep up their load, their volume. Row if possible. Obviously, if it's very sore, they won't do that, but even on the ergo, in the early phases, obviously not the first few days, and then get them going through those squat progressions as you can. Then you're going to progress to, in the boat, motor control, keep going on your squats, hip hinging, loading the posterior chain with things like deadlifts are important. Get that big muscle group used to getting loaded. And keep assessing response to training, so top up. Where they can't do the water work or their sport work, top it up with other work. And then the return to training is a strength and condition graduated increase in load in trunk. So things like deep squats, Romanian deadlift, inner range hip flexors. And assessing all the time the response to training. Exercising with pain is quite the challenge, isn't it? But we know now that we're really moving on in terms of how we look at that. And maybe it's okay, because we know there's a lag in pain and recovery, and particularly we're thinking of specific tissue damage. Do we need to reconceptualize pain? So traditional models talk about nociceptive, but I think you all know it doesn't always provide a measure of pathology. And sometimes our language can actually embed something in the athlete. So see what they understand, challenge unhelpful beliefs, so that hypervigilance, and enhance self-efficacy and safety cues. This is a little monitoring program I'd use. There's obviously apps out there, but this is the simplest. It gets them to use it. So their sleep, their RPE, their pain that day. And I don't want them to go above 4 out of 10 when they're rehabbing. So when we did our consensus statement, we made sure we got athletes and coaches. And this is a nice bit of mapping that we did. So we wanted to know prevalence, can it be managed, can it be prevented? And that's in our paper, if you want to have a look at that. So where do we need to go? We need loads in low back pain, actually, in athletes. We need to know when we can let them return to sport, how we manage pain, how they understand pain, a specific low back pain questionnaire. That's why the mess was with the forest plot. Risk stratification tools. We need to flag early if they have something like inflammatory arthritis. Those of us who treat a lot say if you've got unremitting leg pain, that's not a good predictor. So better high quality research and specific pathways. So that's where we ended up. So letter to my younger self, it'll be okay. That's me 2 weeks ago racing in Boston. So it all came good. You know, got there eventually, bit old for the Olympics. That'll never happen, but it's okay. I just row with the ladies and have great fun. And it gave me that rich experience. So hopefully I've been able to give it back to athletes and help. So thank you very much. Take some questions.
So are there questions in the room to Fiona?
Yes.
Thank you for your nice speech. I have a question regarding the meta-analysis on the prevalence of low back pain.
Mm-hmm.
I was wondering, did you do any subgroup analysis to see if there were athletes with a higher prevalence of low back pain than others?
Oh, certain sports?
Yeah.
Yeah, so we looked at that and we couldn't really. There were certain sports that it's just because they weren't reported well enough. So we looked at that. Things like obviously rowing, gymnastics, soccer, football, there was high prevalence, but they were spotted around. We couldn't even compare those studies. So we avoided actually ranking it by sports, and we've got a table in that paper which shows the different sports. They weren't reliable enough that we could say all of these have used the same method and high quality so we can compare. So I say at the moment we still don't really know. I think as clinicians we have good ideas of certain sports like rowing, swimming, tennis, gymnastics. We see a higher prevalence of low back pain, but the data isn't there for us to be confident in making that. Is that what you're asking me?
Yeah.
Yes.
Okay. Thank you.
Une autre question de l'audience? Peut-être? Non? Sinon, je vais... Ah,
Là.
là-bas.
Nog iemand?
What's your opinion on exercises where the spine gets loaded in a flexed position, like the Jefferson curl?
Yeah, well, rowers do that every single stroke. Yeah. I can give you a little bit of... There's a really great paper by a guy called Richard Ashton, who's a bioengineer, who talks about a bridge. You know how bridges are that shape? And they're built that shape because they bear loading really well. So he's used that model. But the human spine can tolerate load very well, like that. I think that information about lifting was to try and make people use the big muscles around their hips, which are the glutes. And it kind of got lost then, where you get this hypervigilance with this people bracing their trunk in lumbar extension. And those cases where people hurt their back lifting, I would say the vast majority are because they're deconditioned. Rowers, they're not tolerating the load. It's cumulative loading. But, yeah, I mean, people freak a bit when you say that, don't they? But we see it all the time in sport. And every single stroke you take as a rower, you've got a bent spine. And the vast majority are okay, and most rowers recover very well from low back pain when they do get it.
And I'm going to ask one question that came over to Slido. I'm going to combine a few questions. Thank you for all the qualitative studies. I think it's really important to understand what athletes are going through. And you talked a lot about the psychological side of things, of low back pain. What measure do you have in place? Do you work with psychologists, or what do you do?
So we did, actually, we have done, and we try to do it in the multiple components that we measure. So wellness questionnaires, profile of mood states, things like that. And I think that's fine. Athletes lie on those. I was only talking to someone yesterday who said I lied in case the coach saw it. They didn't pick me. Mm-hmm. I think as a physio, you're a safe space. You're often the safest space in the team. And I think that's why it's really useful to have those long conversations and have them again and try and understand the psychology of what that athlete is getting through. I think we're quite good on it. I remember I would have then gone to the team psychologist and discussed it that way. This is what they're telling me. And maybe then they go to the psychologist in a safe space. But I think those tools, I think they tend to lie. Maybe I'm wrong. Maybe there's good evidence that they don't. But certainly my experiences are a bit mistrusting of how those tools or the information is used.
Thank you. I think we have time for one more question. Yes.
Hello, thank you. I had some experience with rowers, but I don't row myself. But do you think that it can be that when they row in team and one is stronger or more or stronger than one, if they have not enough force and they want to win, then they don't do it with their arms, they do it with their low back. Or also asymmetrics, if they have more power in the right hand and in the left, and then they turn a little bit by getting more force. Did you know anything about that?
So actually, when you row, a lot of power comes from your back. So not really your arms, so your arms just lock on. And a lot of the power comes from your back. That's why your back needs to be strong, and that's why they need to be loaded in training. So it's your whole posterior chain, actually. But if you do get mismatches in teams, that woman I rowed with in South Africa, she was an absolute demon. She was an amazing athlete. She was better than me, that's for sure. And I even look at that picture and I think about the psychological stuff. I felt I had imposter syndrome. I got picked with her and I just, I'm going to lose her and I'm going to die. I'm going to get beaten. So that, I didn't even think about that at the time. So that can happen. It's getting better because we've got things like force transducers on oars now, which will tell us exactly how much they're pulling. So it allows coaches to make a better judgment of the athlete in the boat and match them. And then there's other scores that are used. So as we're getting more sophisticated in our team selection, I think that will decrease. Asymmetries in back pain, the evidence shows us that it's not significant. It doesn't seem to make a big difference because we're all a little bit asymmetrical.
Good. Thank you.
Gut, ich wechsle wieder auf Deutsch. Ich glaube, wir müssen so weitermachen mit dem Programm. So we will
thank you. Thank you.
Stop here.
Thank you very much
for your presentation.